So this is about summary orthopedic surgery, open fracture joint replacement. What is the mechanism? This is, you can see, this one is because of tension. This is stretch from two sides. This is compression, axial. So this stretch will cause transverse fracture and this will cause oblique fracture, and this is bending. Here is 4.2 multiple points, so segmental fractures. This is torsion, this is spiral fracture. See, you can see the person is trying to catch this something and he got stretch, and this is someone is jumping from height, he got axial compression. If some injury directly from the side, you get this type of fracture. Motor vehicle is hitting on the thigh, you get multiple segment fractures. So here there is skateboard a person is using, there is twisting fractures. Fracture patterns, fracture is breach between the cortex and the bone. Two factors that determine the type of fracture. The results are amount of energy and way in which done. Mode of the energy, tension may be transverse, axial compression, bending forward, and all this. There are few other important fracture types. Avulsion occurs, strong ligament or tendons is pulled off from the bone. Green stick fracture, buccal fractures are also called as buccal, is incomplete fracture in children. Pathological fractures occur at the level of trauma and not normally expected. Stress fractures, repeated minor trauma may lead to this march fractures and all that. Amount of energy in order to generate a fracture, energy may be more energy applied, kinetic energy, and kinetic energy is equal to greater energy results in more complicated patterns, and that is called comminuted fracture. Is associated with high visceral injuries to vessels, neurovascular, or any abdominal organs, they may be injured. Soft tissue injury, subsequently compartment syndrome and neurovascular deficit and stripping of the peritoneum and compromise the blood supply to the fracture fragments. Description of the fractures depends upon the parts and names of the acronym. Pattern: transverse, spiral, oblique, butterfly, comminuted, and displacement fractures. Displacement is described with reference to movement of the. So what is this displacement? Movement of the distal part relative to the proximal part. So these are the two parts. For example, this is the distal part and this is proximal part. So displacement, dorsal, lateral, medial. So it is the distal part in relation with the proximal part. So dorsal displacement. Angulation, varus or valgus, anterior, posterior. Varus means out. Valgus is out, varus is in, and anterior and posterior. Rotation usually appreciated on the X-ray, showing joint above and joint below. Showing the joint above and joint below. Rotational injury. Translation: movement of the distal fragment anteriorly, posteriorly, laterally. Shortening, pull of the muscle causes shortening of the leg or the arm. Open fracture definition: when the fracture has hematoma and broken the bone ends and the fracture hematoma communicates with the epithelial surfaces, it is called as open fracture. The open fracture does not always communicate with the skin. It doesn't mean that it should communicate with the skin. It can communicate with any of the pelvic cavities. Pelvic fractures may communicate with the rectum, vagina, maxillofacially may communicate buccal cavity. In addition, bone ends themselves do not have to protrude through the epithelial surfaces. The laceration that is continuous with the hematoma constitutes open fracture. Sometimes it is difficult to decide if the small puncture wound communication with the fracture hematoma. One sign that is pain, often helpful in presence of continuous flow of venous bleeding in any event. It is important to high index of suspicion. So the classification: open fractures are described by Gustello-Anderson. This is open fracture. Gustello-Anderson classification based on the amount of energy and required the energy of soft tissue damage, and it is basically so low energy impact, very small, and there is very small, less than 1 centimeter. Again, second to Gustello-Anderson is low energy impact, less than 1 to 10 centimeter. Third, A, B, C. Third is high energy impact with loss of soft tissue skin injury is much. In third, there is loss of soft tissue, and fourth, there is vascular injury. Problem associated with the open fracture: early problems immediately. What large amount of energy required to open fractures, especially type 3 fractures. Patient at risk: multi-system injury, compartment syndrome, nerve and vessel injury. Problem associated with the open fracture: later problems are infection, periosteal stripping. There. Open fracture treatment: British Orthopedic Association has published guidelines what to do in the open fractures. Initially, you have to assess this life trauma support principle. Careful assessment of the limb and neurovascular status is important. Remove the gross contamination, wound photographs and saline soak, gauze and impermeable membrane, clingiform. Avoid repeat exposure of the wound. Avoid provisional cleaning. So it has to be provisional cleaning in everything has to be done. If the fracture is grossly displaced, then try to restore the alignment and then splint with the back slab. Antibiotics and tetanus prophylaxis has to be given. Obtain X-ray, 2 views X-ray. Assess for presence of compartment syndrome. Wound debridement should be performed in theatre by senior surgeon on schedule operating list in daylight hours within 24 hours of surgery. Indication for immediate surgery are gross contamination, compartment or vascular compromise. Primary amputation may be considered if the limb has been avascular for more than 6 hours. So joint replacement. Total joint replacement arthroplasty is a surgical procedure in which parts of arthritic damage is there. Hip and knee replacements are most commonly performed joint replacement, but replacement surgery can be performed on other hand as ankle and wrist joint. Patient with osteoarthritis and advanced symptomatic osteonecrosis with secondary osteoarthritis benefit from non-operative treatment, physical physiotherapy, intra-articular injections can be given. Total hip joint arthroplasty, including THA and knee arthroplasty, had demonstrated success in reducing pain in osteoarthritis also. Decision when to go for total hip joint arthroplasty in the patient who has symptomatic moderate advanced osteoarthritis shared decision. In patient with moderate to severe arthroplasty advanced directly. For the patient who have obesity and moderate to severe symptomatic osteoarthritis advanced recommended against the increased risk of medical complication. So indications for knee replacement are knee osteoarthritis, NSAIDs, it is failed, decreased knee function cause arthritis, inability to lose the prosthesis. So that is about open fractures. Now let us see what is this Perthes disease. Summary of orthopedic surgery. Perthes disease normal is like this. There is and this is DDH. So we will see the conditions in pediatric patients. Perthes, Scuffi, normal, dynamic dysplasia of the hip joint, or it is also called as congenital displacement of the hip, dysplasia of the hip joint. So Perthes disease is known as Legg-Calvé-Perthes syndrome, named after 3 doctors, Legg-Calvé-Perthes, who first described the condition. Perthes is idiopathic osteonecrosis of the femoral head. The head is osteonecrosed. As the head loses its blood supply to generate pain, the dead bone collapses and head loses its spherical shape. Risk factor is Caucasian boys, 4 to 8 years is the age group. Males to female ratio is males are commonly affected. Small stature, immature bones, living in a poor urban condition, exposure to passive smoking. Associated with ADH, possibly due to trauma. Also with congenital urogenital abnormalities. There is association thrombophilia, clotting abnormalities, implying the disease related to interruption in the blood supply. So blood supply to this surface is interrupted. That's why it leads to loss of Perthes disease. There are pain in the hip and groin. Occasionally pain referred to the knee. There is AP pelvis, 2 frog and lateral view is taken. Initially necrosis X-ray may normal, occasionally widen space and may represent effusion joint. So this is the finding. You can see this is one, this is another. You can see in this displays fragmentation state, dead bone is reabsorbed, subcontinental fraction, extent of the femoral head, worse prognosis. Extra-Perthes disease, right femoral head in a 6-inch and fragmented state. Now reossification, new bone is laid down and process may take 18 months. Remolding, the head remolds and it is remolded. X-ray of the small child, 5 years. There are 3 main factors that determine the risk of arthritis and long-term pain. The age of child, younger the child, more chances to remold. Therefore, do better. Children less than 6 years old have poor prognosis. Extent of the femoral head involvement, how much head is involved, abduction contracture. Most cases are treated conservatively with active modification and period of partial weight bearing with hip painful. Should be carefully monitored with loss of abduction and if the head is no longer pain. Now 6-year-old child with a gross pain, he is known to be disruptive in class. He reported that he is bullied for being short, and on examination his antalgic gait and pain on the internal rotation. So Perthes, transient synovitis, sleep development dysplasia of the hip joint and septic arthritis. Most common diagnosis. Slip, it is also called a slip capital femoral epiphysis or slip capital femoral, formerly known as slip upper femoral epiphysis. This is the epiphysis is caused by weakness in the growth plate and resulting femoral disc slip. This causes chronicity, acute and chronic symptoms, stability. The slip may be stable if the patient is weight bearing The risk factors is age is 10 to 16 years. Male obesity is again there. Obesity is the factor. Down syndrome. Child often present with limp and groin pain. Investigation should mainstay. And frog view has to be done. This line is lost. This is called as normal, and Sufi Tron Klein line reveals slip upper. This is the line. You can see there is slip. Once this is slipping down, this is slip down. So severity is depend upon, this is lateral displacement. Severity depend on angle between the line from the femoral neck and lateral view, another line perpendicular to the epiphysis, 30 degree, more than 30 degree, 60 degree. For 4, most common aim of surgery is to prevent slip from further slipping. The single screw can be placed, and so dynamic dysplasia of the hip joint, congenital condition. So this is Sufi, age is 16 years. Now this is congenital, DDH is congenital, in which femoral head does not congruent with the acetylum. There is spectrum with the clicking sound in the hip and partial etiology factor. This first born child, breech presentation, oligohydramnios. So clinical picture is male is again more common, 4 to 8 years. You see gluteal folds. This is gluteal fold abnormality. They are not touching at the same level because there is some joint is slipped from here. Therefore, this is one gluteal fold. This is an abduction range movement. You can see here this is less and this is more. So this is 40 degree only. This is 80 degree. Now this is what you have done. Push the femur backward. So here you are pushing it back down, and with the thumb you are trying to move it out. That is Barlow. Take it out. And Galeazzi, no difference. This is the height. This is Galeazzi test. The height of this knee is above than this. And alternately, you are just trying to put it inside. This is lateral abduction movement, and with this is putting the head inside. Before 6 months, so AP pelvis child, dislocated right femoral disc, Helgener's line and parallel Perkins line. These are the two lines. The left femoral is normal, left is normal, right is displaced. Ultrasound, real-time visualization of the movement of the joints. As patient is very young, the X-ray cannot be found, so sometimes ultrasound. 4 types pattern. Coxa magna, premature physical arrest, irregular head formation. So this is the pelvic harness. So person is given this type, baby is given this type, 6 to 2 months. Then if the 6 to 2 months arthrogram will show reduction hip spica is this. And over 5 years you have to do pelvic osteotomy. So coming to this last topic, this is actually not only orthopedics, it includes orthopedic surgery as well as this is a Glasgow coma scale. I was explaining the eye opening, mouth and verbal response. What is ATLS protocol in polytrauma? First of all, you have to go for primary survey, assessment of the vital functions A, B, C, D, then fast scan, AVN, lateral, patient is stable, then you can go for secondary survey, head to toe assessment, multiple polytrauma and reassessment, ATTLS. If unstable, damage control surgery, life-saving surgery, intensive care, delayed primary survey, then you do surgical management of life-threatening injuries. And here ATLS algorithm, A is airway, B is breathing, C is circulation, D is disability, E is exposure, assessment is airway, then chest, rib, and all these. Stages of healing of bone fracture, week 1, 2 to 3, 4 months. Initially there is hematoma, then is inner callus formation, external callus formation, there is bony, spongy bone, and then consolidated bone. Gustilo Anderson, it is for the open fracture 1, 2, 3, 4, 1 less than 1 centimeter, 1 to 3 centimeter open soft tissue. How much soft tissue is lost? Neurovascular is lost. So this is Salter Harris. You can see S is for the straight line, A is above and B is below, and T is both above and below. So this is the spinal vertebrae. You can see this is compression fracture on this side and this tension fracture, stitch fracture. So compression may cause this type of burst in the body of the vertebra, and this is again this different types of compression fracture dislocations. Now this is cauda equina and bronze section of the spinal cord. You see findings of cauda equina syndrome. Are you having any of the symptom? Orgasm changes, retention of urine, sciatica. Because cauda equina, this is the annulus fibrosis, this is nucleus pulposus, these normal roots are involving arriving, there is a central leaf called leg dominant. If it is compressing the that is leg dominance, cauda equina syndrome is like this. It is central cord compression. Brown sequence is the hemicord compression. Loss of pain temperature on the opposite side and power on the same side. You get syringomyelia is a central cord compression. So upper motor neuron lesion, the upper motor lesion, cerebral hemispheres have brainstem is hyperreflexes. There is no inhibitory control from upper motor neurons. So this you can see clearly CTV. It has got congenital talus equinovarus. This has to be treated by the modified boots of different levels, which can be used. So sleep now X-ray sleep upper femoral Sufi congenital talus equinovarus. Then this again the bone fractures at the hip joint. You see this is capital fracture. This is neck of the fracture. This is intertrochanteric and subtrochanteric. So here the blood supply to the femoral head is seen. A deep arterial artery gives branches, that is ascending artery. Now these are the types of 4 different types of surgical neck humerus. This is type 1, this is partial injury, there is no displacement. Type 2, there is total injury but no displacement. Type 3, there is displacement. 4 is major displacement. Now roots of the damage, how they are involved, which is important nerve, which axillary nerve. These are the axillary plexus, brachial plexus are important. So this was about lower posterior dorsal fracture, that is Horst Lemstein. This is C5, 6 dermatomes of the skin. Here is patch area C5. Then you go down. This is C6, C5, C6, C7, C8, T9, and C7, C8. C8 here and here is the T1. Ulnar paradox: injury at the wrist joint gives more damage because injury at the pelvic joint is little bit. FDS is supplied also by ulnar. So here if you get an injury, FDS is supplied with this and you get. This is cubital fossa. Injuries supracondylar fracture more common. Brachial artery or the cubital is more commonly injured. This is anatomical staff hog. This is middle joint. You get the nerve supply of the upper hand. This is the nerve passing below the piriformis. Sciatic nerve is the most common. You can see this supply sciatic nerve, one tibial branch here, superficial common femoral, superficial common femoral nerve. This is the anterior of the chest. This lateral thigh. This is medial of chest nerve. This is lateral thigh. This nerve supply of the soul. These are the compartments of the bone. This is femur triangle. This is the toe ankle injury. This is the medial lateral rupture, lateral malleolus, and even you can see on the posterior view. So this is squeeze, Simon squeeze test to understand the tendon rupture. It's attached to this tendon is attached. Now this is important. Orthopedic infections in the children. Most of the time we get confused chondrosarcoma, Ewing sarcoma. So epiphysis is the terminal end and metaphysis is in between and diaphysis is the bone. There is a growth plate. The physis is a growth plate. So epiphysis, adult GCT, or then you get metaphysis, osteochondroma, osteosarcoma. These are diseases of metaphysis. Bone cysts can also seen. Chondromyxoma. So this is about. And diaphysis has got osteogenic dysplasia, stress fractures, fibrous dysplasia, round cells. Osteopetrosis, hard brachial bones, and this is scurvy, vitamin C deficiency,